both have agreed to be recorded, so you can record if you'd like. Okay, so Sawadika, I will introduce our amazing speakers for tonight, and thank you for moving it from last week. That was my error. Let's see. Let's start with Timothy. So Timothy Quinlan is our orthopedic resident at OHSU under the direction of Keegan Fitzgerald, both DPTs, Doctors of Physical Therapy, and he actually came to OHSU in 2022. So he'll tell you a little bit more about his experience, but we're really excited for him to teach you what he has learned as an OHSU resident. And then we have my friend and long-term colleague, VJ Judge. Some of you have met VJ before, and you'll see in his presentation, he does try to write in Thai. VJ is a fellow Canadian, so you know that's another positive thing. I hired VJ into a professional practice leader role at OHSU for our value-based programs, bundle payment program for comprehensive joint replacement. And so he is the guru of care transitions, care management of these patients. And VJ can tell you more about his life in Vancouver, BC, which I bet everybody wants to go to Vancouver. So I'm going to let the speaker start. Please use the chat for any questions you have throughout. I'm sure they'll stop and ask any question or demonstrate for you. Or please, you can raise your hand for them and we'll get going. Thanks so much, everyone.
Did you want to
All right, how's it going, guys? I was like, VJ, did you want to go first or?
Connie, what was the plan? Was it first or?
Do you guys want to, I can throw a quarter up in the air. It doesn't actually, what comes first? What comes first? The physical therapy prehab or the care manager?
Both, actually.
Oh, darn. Okay, call heads or tails, VJ.
Heads.
It is heads. VJ's first.
Okay, I'll go first, Tim, if you don't mind, if that's all right. Thank you. All right, I'm going to share my screen first and make sure that everybody's able to view. One moment, please. And can you hear me okay, by the way?
Fantastic. We can see it.
Can you see my first screen?
Yes, we love the Sawadi.
I hope I translated it correctly for everybody. So thank you. Yes, again, a lot of thumbs up. Appreciate that. So my name is VJ Judge, and I'm a registered nurse case manager, and I joined OHSU about almost 10 years ago now. And as Connie said, that I was hired in as a professional practice person, and the role of the nurse coming into doing elective hip and knee procedures was a key change, a fundamental change actually in care coordination. So my role is that I'm an RN case manager, but my primary role is to focus on elective hips and knees and preparing them for their surgery. And I visit them also when they come in for their inpatient stay. And I also follow them for a 90-day period. There are two of us that do this. My colleague Melody does the same role also, but her focus is the same as mine, but with a different insurance group. I also, in addition to the hip and knees, I also follow the shoulder replacements and all the fractures of the lower extremities. And I think somebody that needs to put themselves on mute because there's hold music in the background. I'm not sure where that's coming from. Okay, I'm going to carry on then. So yes, I also follow the shoulder replacements, the fractures of the lower extremities, but I will be primarily focusing on the hips and knees for this particular presentation. So This is my workflow and my colleagues' workflow, and we get alerted to patients who are coming in for elective procedures. And over here is the first stage of where we see them in the pre-op
น้อย
area.
มาฟังโอเลกอนไหมอ๋อโถอ่า
Ferris, it's
Somebody has to
Malika.
mute.
That's not muted.
Okay.
I think Ferris, you'll have to mute her because I'm not,
Oh, okay. You want me to mute them or?
I don't know if you can. Ferris is the,
Okay, it sounds like they're muted now. So.
okay.
Okay. So this is my workflow, and basically it's what Connie said is we're trying to transition our patients through a continuum of health, and there's 3 points where I touch them, and I see them in the pre-op area, which can be anywhere for 30 days prior to their surgery, and some of them could be a lot longer. It could be up to 2 months, 2 months depending on how complex they are. So all I do is the preparation and the planning for them before they come in and do a risk assessment on them for their care needs. And then the second stage is when they come in for their surgery. And then also their inpatient stay. Over here, we've got 3 days, but what we do now is we're discharging either the same day or we're discharging the next morning. So our average length of stay has, I think, recently been 1.2 days. So the third part of it is when they get discharged, I follow them for a 90-day period after. And I'll explain why we do that and what the quality metrics are for that. In the end, we get information back from all of our insurance payers, and we are able to track spending so that we can make it more of a value-based care system. And I'll explain that more. And so all of this is going to be shared decision making. That is, I'm always working with the likes of our physical therapists like Tim and Keegan, and our occupational therapists and our surgeons. So in the pre-op area, and we basically look at their patient support systems, medical equipment, and discharge disposition. So their discharge disposition is the main goal of my appointment with these patients. After I confirm their surgery, whether it's going to be a hip, knee, or whatever, left or right side, I go through a series of questions related to their support systems. So we use some risk tools here. And one of our risk tools is called the Risk Assessment Predictive Tool. It's called RAPT for short. And I'll briefly talk about that. And then one of the things that's not so medically driven is what's called the social determinants of health. Now, social determinants can be a big impact on patients when they come in, because if we didn't do some of this pre-work before they come in, we have a risk, patients that are at risk that could end up costing a lot more because they're homeless. And they didn't tell us that prior to coming in. So these are some of the tools that I use to talk to them about coming up with a good discharge plan. The RAPT is very highly reliable, and the social determinants of health are our nursing case management's best practice tools to help determine a discharge plan. This is a very basic tool, the RAPT, the Risk Assessment and Prediction Tool. We use these very easy questions, as you can see along here, to figure out whether they're going to need extra help when they go home because they live alone, or are they going to need home health, or are they going to need to go to a rehab facility. In the US, we have to document the reason that we are supporting a rehab facility so that insurances can pay appropriately if they do need to go to a rehab facility. The first few questions are very, very easy. The age, the gender, and the weighting of the scores are, pretty average here. And then how far on average can you walk? And then do you use any kind of gait aids, such as a cane, a walker, or a wheelchair or electric wheelchair? And then if they're using any community support systems, such as someone coming in to do their laundry or nursing coming in to see them. And the last question is the heavily weighted one. It's either a 3 or a 0, because this will determine whether what the trajectory of their discharge plan is going to be, whether they have someone that lives with them that can support them, because sometimes they can have someone that lives with them, but they may be the caregiver for that person. So in which case it would be a 0. The score is out of 12. Anything less than a 6 means that we have to take a look at other options after the surgery, whether they go home with support or whether we need to put them into a rehab facility for a short term of 7 to 10 days before they can go home safely. And that's what I figure out for them and then help them plan for that. If they have a score of 6 to 9, that means they're a medium risk, which means that, they can go home, but we need to put other supports in. Or if they're living in their car or they're homeless and they have nobody to help them, there are other alternatives that I can offer them as a safe place to go to. We have plans here, social plans that can help them with housing, safe housing after surgery like this, especially after a hip or a knee surgery. They can't go back to their tent if that's what they live in. So anything greater than a 9 basically means they can go home and they may only require one thing, which is outpatient physical therapy or a home health physical therapy visit. The social determinants of health, looks at their living situation, and what we're trying to ascertain here, this is slightly outside of the medical model. And for the US, the safe disposition prior to surgery is a very important thing to talk about with people, because when they come in for surgery and they haven't had a screening by myself or a care coordination appointment, if you will, what happens is their discharge becomes very complex, because there are certain places for rehab that they can't go to if they didn't have a home prior to coming in for surgery. So this can encompass many determinants, but it means it's a collaborative, because often the physical therapist, the occupational therapist, and the surgeon have already talked to me in advance and saying, hey, VJ, we know about this person that's coming in. They're going to be high risk. What can we do to make it a successful surgery for them, because they desperately need surgery? So I take a look at all these factors, and there are some times where I have to turn to the surgeon and to the teams and say, we can't do the surgery because this patient has lived in 5 different places and they've burned down the place each time. So these are things that I have to figure out and do a lot of social digging to find out what they were like behaviorally before they come in. And it saves us from bringing somebody in, which means that ultimately they may come in through the emergency department. At that point is where we serve them. We also cover all these 4 things over here, which is the addictions, who their support persons are, if there are any. Transportation, that's a big issue too. Do they have any money to be able to get transportation to and from their surgery, to the facilities that we've set them up with? And then I go over all their options if they're homeless. So that means that if they were living in a tent before, we have many options that we can take a look at, but it would have to be a good fit depending on their behavioral context and their psychiatric readiness. So the inpatient portion is where I review the discharge plan from our pre-op care coordination and discuss whether everything is going according to plan. If a person comes in and we find out that it's not going to be safe for them to go home as we predicted, as per our conversation in our care coordination appointment. I'll just wait for that to stop.
Serena Corinne, can you please mute? Thank you.
There. So at that point, what I do is I do a reevaluation with the patient. If the goal was to go home with home health and it turns out their support person got sick and there's no one at home for them and they're an at-risk person, such as a geriatric person going home, then we change the plan to going to what we call a preferred partner home health, to a preferred partner skilled facility or an alternate level of care, and just to make sure that they're safe, and we can make that change on the fly. So what's the purpose of my discharge planning? Basically, what we're trying to do is make it a value-based care across our institution, which is a standardization of all of our approaches on our hip and knee replacements that are elective. So the 90 days after the surgery, a lot of people have a lot of medical problems. So our biggest problem in the US is preventing readmissions. So that means if we can keep them at home, and if we have home health going in to see them, the nurse can do preventive measures to try to keep them at home, or if you have to bring them into the emergency. Thank you. Okay, so the biggest thing in the U.S., what we're trying to do is prevent readmission because the biggest cost in 30 days after a surgery. Okay, so sorry, I'm still hearing people. Yeah. So in the U.S., we're trying to prevent readmissions. It's very costly for insurance companies, for the patients, and we try to bring them into our emergency department to redirect their care and send them to an appropriate place. I'm so sorry, but there's still people unmuted.
Serena Corinne, can you please mute? Your conference room is not muted.
Thank you. Okay. Sorry. So we offer additional support. I continue to follow them. They will call me. So we also have tools that we use, and they use them on their smartphones, and it's called the GetWell app. And the GetWell app helps our elective patients get pre-op reminders of how to or stop surgery. Stop medications prior to surgery. And then in the 90 days after the surgery, if they're having problems with pain management, constipation, nausea, they usually call me. And in this app, it's almost a real-time activity with them so that there's no delay in their care needs. It's highly, the satisfaction is so high with this GetWell app with our patients, they really enjoy using those. The biggest thing that we can think about is geriatric considerations. Many of our patients who are geriatric, they're living alone. I say here 65, but on average, it's people who are over 78 anecdotally. They have limited access to support and are most vulnerable, those ones who live at home at risk. So those ones that I would ask for a geriatrician to come in to look at them too. And that's something that we freely do with our geriatric program. And these outcome measures are so important to us so that we can see how we measure up with the rest of our nation. And financially, the over 65 age group is increasing, so it has to be financially sustainable. And there's a rising number of the population being over 65, and that's common everywhere, I would say, and needing hip and knee replacements. So we have to make it sustainable for those who have certain types of insurance. And so our greatest goal is to try to keep them out of the hospital, hence the reason for following them for 90 days, because our biggest hit is always in the first 30 days where they can end up being readmitted, which goes against metrics and measures here in the US. Questions? And that's it for me.
Thanks, BJ. Maybe we'll take some questions at the end then,
Sure,
if you don't
yes.
mind. I love that horse and
I have a questions, Connie.
Okay, please.
So right now we also use IAPT since 2 years ago that you show us the IAPT. So we are collecting data about this as well. But in our facilities, I would say that we don't have much from the patient that go to high risk. It's mostly like medium risk or low risk. So in the medium risk populations, what would you arrange them to come back for the PT, or you ask them to come as an outpatients or something?
No, that's
for
a great
the
question.
medium risk?
That's a great question. Yes. What I would do is let's take an example, a medium risk person that's homeless. They don't have a home to go to, so we can't send them to a facility. So we have social programs that we can use through our social work department. And we have something called the recuperative care program. And what we do is we ask for funding for that patient to go there. And when they go there, they either get a private room or a shared room, but there's no skilled people that are there. It's basically a safe place for them to go to recuperate for their hip or knee. And then what we will do is we will have home health go and see them. So a physical therapist will visit them at the recuperative care program, and also nursing if it's needed for any kind of wound care or medication management. And the caveats that need to be in place first. So anybody that goes there already has to be able to move on their own before coming in so that the goals can be met when they get discharged. Does that help answer your question?
Yeah, sure. But I think here is going to be a bit different because most of the Thai population, they have someone to take care of. So for the medium risk group, yeah, I would say that your recommendation is also great to see the safe place.
Thank you. Yes. Yeah, I wish it was more so like that here too, but this is what it is here.
Yes, and another question for me, after discharge, like you follow up them for 90 days, right?
Yes.
As a case manager, and do you have like any tools or any outcome to assess them, like to compare, like after like prior discharge immediately and after 90 days? Do you have any tools for that?
Yes, basically, from a nursing perspective, I use my nursing acumen. Basically, is the interventions that we provided for them working? Okay, so it's a pathway. It's a pathway tool that we use. So in other words, are they still having pain? Is this a exorbitant amount of pain that's not normal for after the surgery? So has it gotten better or any worse, or is it just is it just continuous? So there could be something else going on. Now, when it comes to physical therapy, I don't pretend to be a physical therapist. I leave that to my higher colleagues. And what I do is I ask the home health physical therapist to assess the patient to see if they need to come back in for an assessment sooner in case something's dislodged, because that could be a potential problem too. The reason that I'm involved is so that we can capture these problems sooner instead of letting these patients sit who are very vulnerable, especially the vulnerable ones, the geriatric patients, the homeless, have nowhere to go after. We try to make sure that they're are kept safe and that they're being heard, and we're attending to their care needs.
And you have another hand up? Yes. Go ahead.
Hello?
Hello.
Yes.
Swadika.
Do you provide home therapy? Now, during your visit with them, do you provide home therapy for them?
Oh, not yeah.
Therapy at home in your hospital service?
I provide the service to set up all the home health services and anything like that. So that means another service will go in and they follow our direction. And that is the preferred partners that we work with. However, I do go in to see patients who are at rehab facilities to make sure they are on track still. For example, some of these patients don't want to leave, and they have to leave because the insurance will no longer cover their rehab stay because they met their goals. So I have to go there and talk to the patient about the rules of their insurance and how it affects their stay at the rehab. But yes, there are times where I might have to go see these people, but what we've done now is we ask our home health services that are partnered with us to go and see the patient.
So we have part of OHSU Health. 2 of the hospitals have their own home health agencies. So we use them as much as possible to serve our patient population in the home. PT, OT, speech, social work, nursing.
Thank you.
Okay, and we'll leave any other questions for the end and let Timothy get started.
Awesome. Thank you guys. Let me know if you guys can't see this. I'll share my screen. It's working.
We can see it in the slideshow.
Yeah, that's what I'm going for.
Perfect.
Awesome. Nice. So like a lot of what VJ said, we're talking and we're collaborating between PT and a bunch of other professions throughout this entire process. So there's gonna be a lot of overlap in between what I presented on or what I present on and what VJ just talked about. I just kind of want to give an overview what today is going to be like. Just because VJ did say there is an increasing amount of prevalence of total joint replacements, and we do need to make that financially sustainable for especially our higher at-risk populations. So I want to talk a little bit about that and then talk about some common things that we see in the PT world, both pre and post-operative, some impairments, and then going through what really prehab is for in terms of physical therapy, and then going through it, both the benefits for a total hip and total knee replacements. And then we'll go over some questions if you guys have them. So I'll fly through the beginning just because it's not as applicable. But there are over 7 million Americans living with hip and knee replacements. So this is a very high incidence. And as VJ stated, it's only going to get larger. We have that increasing rate of baby boomers. We're having an increased rate and diagnosis of advanced arthritis, as well as increased demands for improved quality of life. This is one of those surgeries where people are choosing it because it's an option to improve their life. So all those kind of do tie into the fact. And then these are the projected rise. I found in a study from 2018. So total knee replacements are a little bit more common. They project by 2025 we'll have around 1.2 million, and that's only going to increase until 2040, being around 3.4 at that time. Whereas total hip is around 652,000 by 2025. But by 2040, it's going to be around 1.4 million. So both of these are projected to rise knee replacements at a faster rate. So we definitely have to make that financially sustainable for everybody, not just the people that can afford it. And this is kind of the prevalence of knee replacements at 50 years old. It's around 0.68%. Sees at 2.92%, 70-year-olds 7.9, 80 at 10.3, and then we actually see this reduction once we hit 90 years old. All of these are very important. Then our length of stay that I've noticed and all the research shows is that it's between 1 to 3 days. However, like VJ said, we're decreasing the amount of time we're having people in the hospital after total joint replacements. You said around 1.2. So there is evidence for same-day discharging, depending on the risk for complications, like VJ talked about, how they were doing beforehand with their mobility, and afterwards. Like if you have higher mobility going into a knee surgery or a knee replacement, you're going to have a higher ceiling for mobility afterwards. So a lot of it does depend on how you go in. So there is that around between 1 to 3 day stay in the hospital for total knees. And then for total hips, at 50 years old, 0.58%, at 60-year-olds, 1.49%, and then that's just going to steadily increase. And similar to a total knee, we are seeing around a 1 to 3 day length of stay in the hospital. However, total hips do have often a more frequent and more likely chance to go to an inpatient stay afterwards. But there's a lot of other factors that dive into that, as VJ talked about. So these are just kind of what we see both pre and post-surgical wise in terms of impairments. We're going to have the obvious one is the pain. People are going to come in with a lot of pain, a lot of weakness, decreased mobility. This could lead to a very kind of atypical gait pattern and a lot of just decreased function. And one of the ones that I really wanted to talk about is because it's something we can help change. It's not necessarily our direct part of our process of helping them, but something along the lines of depression is a huge factor that we do see. A lot of these, especially if it's a lot of chronic pain patients, no one really has an acute pain that leads to a total knee surgery or a total hip surgery. A lot of these people are dealing with chronic pain, so they're at higher risk of having things like depression and anxiety. And depression was reported in neither a quarter to a half of those with a total knee replacement. And this was either immediately post-operatively or pre-operatively, all the way out to about 1 year out. So this is definitely a lingering impairment that they can have, and something that we can really help address. Even whether that be having them get a referral to pain psychology, who can do that job a little bit better than us. But also, I found it interesting that patients with both depression and a total hip replacement are around 2 times more likely to require a revision than people who are just presenting with a total hip. So that's definitely something that we do want to take seriously and we want to address throughout our time seeing them. So what is prehabilitation? I always kind of refer to surgeries like a marathon, so we do want to train beforehand. And there's 2 main themes that are going to go into this, and it's going to be both education and exercise. And that education aspect is going to be a lot of collaboration between a lot of different fields. Like Vijay was saying, like everyone's kind of talking around, helping out and choosing each other's other professionals that can help a little bit more adequately at that time. So our first one is education. And it's not just timeline to, if any, precautions like we see in the total hip, but also a timeline to general function, as well as a timeline to return to function, to full function. I think this is one that really gets over or understated, just because I do see this anecdotally maybe a little bit of a disconnect between surgeons and patients. That is it's unfortunate. Personally, I've had a couple of patients, not just here, that have had total hip replacements and thought they'd be back to full function within 6 weeks, when this is really like a 9 to 12 month long surgery and timeline to get better for either one of these surgeries. So we do want to go over that timeline for them. Precautions for total hips we'll talk about later. But that return to general function, it can be seen as anywhere between 3-4 months. But in order to return to full function, what they were doing beforehand, like I said, this is a marathon. We want them to know that. We want them to be able to train beforehand. Something along the lines of sleep. It could be as something as helping remove electronics from a room, avoiding alcohol, caffeine. Sleep and pain is kind of a two-way street. You aren't sleeping well because you're in pain, but then your levels of pain are increased because we're not sleeping well. If we can help address one, we can help address the other. And then what Vijay talked about is going over their friends and family support, going over those things. And then we can just educate them on the signs of infection. They're going to have a huge, you're going to want to know what's going on in the body. So we talk about signs of inflammation, redness, swelling, heat, fever, all of those things we want to bring up with them. And then the biggest thing for PTs usually is our exercises. That's what our profession is. And the best thing about this is the fact that there's no specific exercise that I found in the research to proves this is better than the other. This is a really individualized program for each one of them, because PT is not a cookie cutter recipe. There's not just a set of exercise that everyone can do. It really does depend on each person. But at the very least, we do want to give at least a very generic exercise. And this was one that I found had a lot of good results. So if you do around 2 sets of 10 for these for 6 weeks, 2 sets of 10 a day, at least some ankle pumps, quad sets, glute sets. So ankle pumps, you're just going to be pumping your foot up and down like you're driving a car. The quad sets, you're just going to be contracting that quad. Glute sets is going to be contracting the glute. Heel slides could just be as simple as trying to slide your heel to your butt. Short arc quads, standing hip abduction, and then just practicing your single leg stance is going to be something that is very effective. And we want to take a whole body approach to this. So we're going to strengthen what we need to. We're going to mobilize what we need to. We're going to work on balance and stability as well. This is something that each patient is going to come in differently and we need to address. So I kind of wanted to go over, sorry about that. So the benefits of prehab, we talked about, it's training for a marathon. So you're going to have that increased physical preparation in terms of increased strength. We know it takes around 8 to 12 weeks to get some actual true strength gains. So we need to have that in mind when we're prescribing this exercises. It's going to help their endurance. We need them to be able to hold muscle contractions longer. We need to be able to have them stabilize longer. It's also going to help their motor control, help them be able to learn how to use their muscles the right way. If someone's been in a lot of pain due to a hip replacement or walking with a painful hip for so long, the way they walk is going to be different, and we need to kind of retrain them on those things. And it's going to help increase their mental preparation. This is a huge thing. So actually it's been proven to show that has decreased stress, anxiety, and fear. Because if you're coming in with those things afterwards, like we talked about earlier, increased levels of stress, anxiety, fear is going to lead to a higher rate of potential potential revision and potential complications down the way. So the benefits of prehab can't be understated here. So I kind of want to go each total knee and then a total hip, and then take you through pretty much a mock PT session that we would have, or at least talk about what we would do in the first session with them. But for a total knee, there is research indicating that PT does lead to, or prior PT does lead to shorter rehab stays, more of those same day discharged. But more research does have to be required in order to make a concrete decision on that, due to the fact that we are currently in the process of trying to speed up our recovery times, and we're trying to get people out of the hospital a little sooner. It's not really a 3-day stay anymore. It's let's get them to a same day as quickly as we can. So the research definitely has some places that it can go moving forward. And it does have significantly decreased pain on a visual analog scale up to 12 weeks. So they're seeing those pains really drop for the first 3 months after surgery. Afterwards, things do start to level out, but there are significant decreases in pain, which is at least a score of at least 2 out of 10 on the visual analog scale to be seen as significant. And then knee functional scores. We want our knee functioning correctly, have shown significant differences immediately post-op, 3 months and 6 months, in both quad strength measured with isokinetic machines, their flexibility or mobility, their range of motion. And this study used both quad strengthening, flexibility, resistance training. Unfortunately, it was not very specific in which way and how they did that, which is always the best part, because it doesn't have to be one specific exercise that strengthens the quad. There are a bunch of different ways to do so. I actually found this interesting. So HIIT training, or high intensity interval training, when done around 3 times per week for 8 weeks, was found to significantly reduce hospital stays, and actually found that they were able to return to their pre-surgical strength around, on average, 4 weeks sooner than those who did not participate in these. The exercises involved in the HIIT training did vary, included things like step-ups, mini squats, things along those lines, mini lunges. These were completed with 5 sets of 10 reps with a 60-second rest. And one thing that I found very fascinating and kind of hopeful is the fact that a study did show that 12 weeks of prehab, including that quad strengthening, mobility training, and flexibility training, 20% of the patients that participated in that did change their mind about their replacements, and ended up not getting them and had very similar outcomes. So that was always a huge win if we can kind of get the same outcomes as a surgery without having to put our bodies through that. Is definitely hopeful for a lot of people. So this is what our pre-op appointment for a total knee would look like. We would go through some subjective, objective measurements, functional measures, because we do want to measure them before, immediately after, and 3, 6, 9, 12 months afterwards. Our exercise prescription, and then really our education on what we're going to do afterwards. So a lot of these VJ already talked about in terms of their living situation, the home setup. Do they have assistive devices? If it's a walker, a crutch, a cane, what's their family support like? Do they have a plan to return to work? And do they have a plan for post-op PT? Those are all very important things that VJ spoke about. And one of those things that I wanted to talk about is if we do a fear avoidance behavioral questionnaire, that cutoff that I found for osteoarthritis is around a 27.5. So if they're less than a 27.5, that's something that fear is going to play a huge impact on. And it's one of those things that we know we can address by just showing them how important and how safe movement can be. Movement's medicine, and that's what we want to teach these people. So then the things we're going to objectively measure, we're going to look at their gait. We're going to see how they walk. What's different? Do they have a little bit less stance time on a certain leg, or are they circumducting a leg? It's going to be a lot different for every patient. We do want to check patellar mobility. If the patella is not moving adequately in any of the 4 directions, we don't expect the knee to move as well. Our range of motion 0 to 30, 135 is considered normal. And I did find a study that if you go into it, or if you come out of the surgery and have less than 60 degrees, greater than 60, those should be flipped, Brown. Sorry about that. Less than 60 degrees in the initial 2 weeks, you are less likely to reach 110 degrees afterwards. However, if you are more than 90 or equal to 90 degrees of knee flexion in the first 2 weeks, you're more likely to reach 120. Those two signs should be flipped. And then we're looking at our strength, our hip, knee, and ankle. We're looking at the whole kinematic chain when we're doing this. This can be used during manual muscle tests, or it can be functional. Have them do a couple stairs for us. See how that goes. Or we can use a 3-rep max. This can be used for the hip in terms of we can use a leg press. We can use a quad extension or a leg extension or a hamstring curl. See if there's a difference between their involved side and their uninvolved side. And if there is, that's something that we can work on. And so for our functional measures, the main ones that I really found are looking at gait speed. And if having a gait speed of less than 0.7 meters per second does increase your risk for falls, that's something we want to address. And this can be measured through a 10-meter walk test or a 6-minute walk test, something where we can just really time them and see how they're moving. You can use a single leg stance, a 30-second sit to stand, and a minimal clinical change is two sit to stands in 30 seconds would be at the least we needed to see if it's actually effective. And then our time to up and go, and for hip osteoarthritis, anything greater than 10 seconds was deemed as an increased risk of falling. And then community ambulation, we do want that less than 13.5 seconds. So actually I wanted to try some of these for you, with you guys today, just to see where you guys kind of are. So we're going to do kind of our single leg balance and then our 30-second sit to stand. And I have to try to find a way so I can see you guys as well. So I'm going to stop sharing for a second. All right. So what we're going to do is for our 30-second sit to stand is we're going to sit back onto our chairs and we can cross our arms. So kind of our feet are on the ground. Our back is against the back of the chair. Cross our arms, and what we're going to do is we're not going to use our hands for this. And when I say go, we're going to try to see how many times we can stand up and then sit down until our full back or butt and back is against the chair. So one repetition is going to look all the way up and then all the way down. So I want you guys to count how many you guys can do in 30 seconds because I do have the norms where you guys should be on the next slide. So I'm just going to get a stopwatch out and we'll go in 3, 2, 1, go. All right, and we're good. I really hope not as many people are out of breath as I am. So our next one is going to be, you guys can still see me. Perfect. We're all going to stand up. I'll do it with you guys. We can put our hands on our hips. And then you're just going to stand on one foot. For now, I don't really care which one it is. So we're going to stand on one foot, and you're going to time yourself to see how long we can do it. And we'll cut it off for like 20 seconds. Perfect. All right. We'll come back down. Get you guys a good little workout in too. So I'll go back to sharing my screen. All right. Can you guys see the screen again?
Yes, we can.
Oh, thank you. All right. So these are the norms for our functional exams we just went over. So the top left is our gait speed. So anyone between, so our column on the left or in the middle for this one technically is for females, and the column on the far right is going to be for males. So 50 to 59, our females, our norm is around 1.1 meters per second. Males at 1.115. And as we age, that number does decline. So we want to keep it over that 0.7 in order for us to be safe community ambulators. So that's the top left. And the bottom left is our sits stands. So I don't know if you guys were counting. So age 60 to 64, the age match norm for females is 12.3 sits stands. And then for males, it's 14. And I also, like I said, the MCID for those is 2. So it is a pretty large change to do two extra squats in 30 seconds. So those are all some interesting norms. And then our top right is going to be the single leg stance. What's an average amount of time that someone can stand on one leg at a time? I just thought it'd be pretty interesting for you guys to see those. And these will be on here so you guys have them as well. And then for exercises, the big thing, like I talked about, is we're going to strengthen what we need to and then mobilize where we need to. A lot of the research for total knee replacements, both preoperatively and postoperatively, has a large focus on quad strengthening. This can include straight leg raises, quad sets like we talked about last time, step ups, or a seated leg extension machine. All of those things are extremely important. However, if someone's coming into the clinic preoperatively and doesn't need to strengthen their quad, maybe we might focus on strengthening their hip and their ankle. We can work on bridges, squats, lunges, clamshells, calf raises. Excuse me for the typo there. And then we need to gain mobility where we need to. This is going to be once or twice a day. Excuse me, I should have said strengthening. Strengthening should be around 3 to 4 days a week. In order for our muscles to get stronger, we do need them to rest. And then we do need to gain mobility where we need to. So if they need to get better into knee flexion, we can do heel slides, a prone quad stretch, all of these things with just a strap laying in your stomach and trying to bring your heel to your butt. And then our hip mobility, because if our knee's not moving great, we got to focus on our hips as well. This can include a figure 4 stretch or a piriformis stretch. And then gait afterwards. We do want them to be walking properly with an assisted device if they need it. A lot of this is as needed. So we can teach them gait training in terms of a modified 3-point stance when they would put their assisted device, their affected limb, if it's weight bearing is tolerated, as much as they can. And then step 2 with their uninvolved lower extremity. We can talk about if they need to go over stair navigation, if they have stairs in their apartment. And then we do want to put them on a walking program around 150 minutes a week. We want to do this now because I'd rather have them do it now and learn how to use stairs and crutches now than afterwards when they need to. And then this is just education for future PT. So we see total knee replacements pretty much immediately post-operatively. And then they do start outpatient PT around 5 to 7 days post-op, around 1 to 2 times a week. This is this is straight from our kind of protocol for total knee replacements in terms of a walking program. So week 1, they'll start at 5 minutes, 3 times a day. Week 2, go to 10. Week 3, they'll go to 15. Week 4, they'll go to 20. And then week 5, they go to 25. And then we just talk about some swelling control, whether it be ice, elevation, movement. And then we put them on a very generic ones to do at home as well in terms of 10 to 20 reps, 5 to 6 days a week, including those ankle pumps, quad sets, heel slides, knee flexion. And then we do want to focus on getting extension back, knee extension back. We want them getting to full usually within at least 2 weeks. At the very most, we want it before that. So we can just try a goal for 10 minutes to start, just lay with your heel propped up on a towel to let gravity do its job. And I promise the hip one won't be as long because we talked about it a lot already. There is less research behind the prehabilitation for a PT before total hip arthroplasty. But 6 weeks of exercise alone, when paired with education, can drastically reduce the chance of an inpatient recovery time. More than just education alone. Like we talked about, education is great, but education when paired with exercise is better. And this includes strength resistance training, gait training with assistive devices, and just functional activities. And then 6 to 8 weeks of prehabilitation has led to significant post-op improvements in things like the 6-minute walk test we talked about earlier, the timed up and go, and then the chair rise test, which is similar to the 30-second sit to stand, which we just practiced. And then our same things we want to go over for our total hip replacements. Our subjective, same exact slide that I put in for our knee one, just because a lot of this we want to talk about these things. They're important. This is when we're collaborating with VJ. So I'm just going to skip through that one pretty quickly. Same things for our hips. We want to look at their posture, their gait, their range of motion. So our normal 120, 20, 30 to 40, and then 40 to 60 for our hip. I did find that the post-op ranges of motion was varying greatly in terms of how far or how much mobility people regain. So there's definitely a field for a pathway for future research to look into. And then same exact thing for strengthening. We look at their hip, knee, ankle, functional 3-rep max things. Probably use more of a leg press in terms of, or a squat in terms of if we're doing things for functional training for the hip. Our outcome.
You went on mute. Timothy, you're on mute.
Things like our glute sets, our side lying hip abduction, clamshells, bridges, squats, lunges. And then we also want to focus on our adduction, marching, things that keep that hip going. We're not really limited by any protocols preoperatively, just kind of by pain and anything along those lines. And then we also want to focus on our knee, ankle, core, and low back. So this can include a transverse abdominis contraction, an anti-rotation press, step-ups, quad sets, a lot more of the same. We're just kind of strengthening that whole lower extremity and lower kinetic chain. And mobility. If they're in a lot of pain, we can use joint mobilizations to help relieve that, whether it's an inferior mobilization, traction, or distraction. Those have been beneficial in terms of just reducing pain immediately. And then we're going to focus on our figure 4, our pigeon stretches if they're lacking external rotation, our single knee to chest if they're lacking a lot of flexion. Lower trunk rotation also helps mobilize the spine, as well as get some internal rotation and external rotation in there. I'm trying to just speed through this so you guys have time for questions. So sorry about that. Same as thing with our gait for our total hip replacement. We still want them walking around 150 minutes a week. We also want to educate them on their precautions beforehand. They're going to get a bunch of this, but general, it's going to be around 6 to 8 weeks of precautions, depending on the surgeon, and also depending on the method. So the general ones are no hip flexion past 90. So we really teach them to sit with their knees below their hips, no crossing your legs. So no adduction, weight bearing is tolerated. Just an anterior approach, no going past 20 degrees of hip extension for around 6 to 8 weeks. And then no going past hip external rotation past 50. And then it's a posterior approach. We don't want any internal rotation or adduction past neutral because we don't want to stress that that scar tissue or that surgical site. And then our total hip replacement education, what we'll do is same walking program as a total knee. We're going to put them on, they're going to have that PT at the inpatient and immediately at the outpatient with some follow-ups at 2 and 6 weeks post-operatively. And we'll be kind of measuring these same functional measures at each time. And then our home exercise program will give them those ankle pumps, glute and quad sets, heel slides, hip abduction, long arc quads. And then by week 2, or when we really want them transitioning out of maybe a walker, maybe to a cane, we can start doing some more standing exercises, including standing hip abduction and extension, avoiding with the anterior approach because we don't want to go past that 20 degrees extension, and then mini squats and marching in place up to 90 degrees are just kind of things that we have on their idea we want to talk to you about while still in preoperative PT. I know that was a lot. Do you guys have any questions for either VJ or myself?
There is some in the chat.
Oh, sorry, I was was not letting me share it in this screen. How different. I would say they're very similar, and also it may have been a typo on my part between the fear avoidance behavior and the fear avoidance belief questionnaire. We really just want to see how they feel about motion.
Tim,
It's one of those.
Tim,
Yep.
Tim, what is the length of stay of the total knee and total hip? What is your length of stay? Approved. Length
length
of
of stay.
stay.
Like the stay, it's depending. That's one of the ones that we kind of need some more research into. And also, I think VJ touched upon that. We definitely see a kind of transition of around 1 to 3 days. Our total knee replacement is a little bit quicker, having some same day discharges as well. That's one of those ones that future research definitely needs to be delving into a little bit in terms of just because there's a wide range of stays that I've seen, at least. And I would say varying between same day and around 3 days.
Same day is in total knee. Total
Yes.
knee is 1 day. And total hip is how many days?
It's one of those ones where it's not going to be 3 days for everybody. It's going to differ a lot on each individual patient.
In the hospital at OHSU, we average a 3.3 day, but that's average, right? So somebody could be 2, somebody could be 7 days.
Yeah.
It's really about pain control, right, VJ?
Yes, and I think that's a good segue for Pastor Korn's question too. When it comes to pain and belief systems, there's a lot of people that come in, Pastor Korn, I hope I'm pronouncing your name correctly, that when they come in, they have other pain issues before they come in, like chronic pain from fibromyalgia or chronic pain from back surgeries. So we try to make sure that, we educate them and tell them that the pain from their surgery sometimes can be potentiated by the pain of their chronic issues. So we want to make sure that we separate the pain that they had before they came in for their chronic issues with the incisional and surgical procedure that happened for the hip or the knee. So it's about educating the patient, getting around their belief system about their pain control. Often, a lot of times, is if a person is coming in and they're being screened, and there's chronic opiate use. We try to send them to a pain clinic before they come in so we can optimize them and educate them on how to be able to manage the pain and reduce the opiates that they're using before they come in for surgery. So that's kind of to address a bit of Pastor Combs' question. Sorry, Tim, what was the part that I'm supposed to address that you were...
I think you did it, didn't he, Tim?
Okay.
Yeah, you answered it. Got to it before I could ask.
Sorry. Okay.
I have other questions. So my question is, can you share the timeline of how to assess the sit-to-stand test after post-operation like that?
So when assessing the sit-to-stand post-operatively, a lot of it's going to depend on their ability to put weight through their affected limb, as well as their strength in there. That's why we like to do it pre-surgically, at least see how they're doing beforehand. And then, in my opinion, I would probably, once I have them start doing some mini squats, I'm going to have them see how they can do in terms of their 30-second sit to stand. And that's something that we're going to measure probably at 3 months, at 6 months, at 9 months, and at that 12-month mark. I know earlier someone brought up is there a measure that BJ uses at 0 days and then at 90 days when he checks up on them? That's definitely something we can use at the 90-day mark to see if there is any statistical or significant improvements, because that's what's going to tell us if our interventions are going the right way or making an impact.
Okay. And other question is how many hour post-op is your earliest to take the patient walk after total hip and total knee replacement?
That's a really good question, and I hate answering all of these with "it depends." I feel bad not being able to give you a clear answer. Most of the patients that do come in after a post-op like that is around they're under weight bearing is tolerated. Some surgeons I haven't seen too many surgeons putting them in non-weight bearing. I don't really see the efficacy behind doing so. But I would say by 2 weeks, we want them doing some more standing exercise, and we kind of want to get them walking as quickly as we can. Some patients tolerate that a little bit better than others. But I would say goal is by 2 weeks. We want them up and moving around.
Well, let me just address that from a nursing perspective, just to jump in there. So to answer your question, you said how many hours. So what happens is for elective hip and knee replacements, that are standard ones that we do, what happens is I always coach the patient beforehand in my meeting because that's a common question they always ask actually is, how soon will I be able to mobilize? And once they've come out of the recovery room after their surgery, and if I tell them the steps are that when they go to their room after, they're going to sit on the edge of the bed with physical therapy and nursing. And what's going to happen is we're going to see if you're feeling dizzy or not. If they're not dizzy and their blood pressure and their vital signs are fine, the next step is to get them standing. So it's dependent on their recovery of the day of surgery. So what happens is nursing staff are skilled to do some of this physical therapy work, but the actual formal physical therapy doesn't happen until the PT season, whether it's the same day or the next day. So depending on whether they're sick and they're feeling nauseous and they're throwing up or they're dizzy, if all those things are stable, the first goal is edge of the bed, standing up, and then to the bathroom and back. So it varies, but it can happen within that first 24 hours.
And our goal was to have PT visiting the patient within 4 hours after surgery. So depending on when they're coming out of surgery, if PT is still in the hospital, it could be the next morning. And they're seeing them BID, right, BJ, in the hospital twice a day?
Yes, it's a BID in the hospital and also with our rehab facilities.
We also do BID as well.
Oh, sorry. What is that term, BJ? BID.
Oh, sorry, twice a day.
Yeah. We do it also twice a day,
Okay.
BID. Yeah.
Perfect.
Yeah.
Any other questions? Because we are at time. All right. Sawadika, thank you so much. Happy holidays.
Thank you. Nice costume, Connie.
Oh, thank you. I'm glad you like it.
Yes. For
You paint for us today.
merge
For
at
just
once.
for you. just